those who don't know me, I'm Sam White, head of the medical negligence team at Leigh. The topic of today's discussion is mental capacity and childbirth. I'm delighted that we have three excellent speakers to help us explore this issue and the legal framework that applies when a pregnant woman is brought to lack of capacity to make her own decisions about childbirth. For those of you on social media, please don't forget to use the hashtag WHR2020. It is now my great pleasure to introduce our brilliant speakers. We have Victoria Butler-Cole QC, who is a barrister at 39 Essex Chambers, where she specialises in health and social care law, including mental capacity law. We have Dr. Livia Martucci, is a consultant in perinatal psychiatry at the South London Maudsley NHS Foundation Trust, Lambeth Community Perinatal Mental Health Services at St Thomas's, and London and clinical lead for South London and Maudsley Perinatal Community Services. She's also involved in training and has been co-teaching a perinatal masterclass in incapacity and law in the perinatal period. And finally, we have Dr. Samantha Halliday, who is our co-director of Durham Centre for Ethics and Law in the Life Sciences and Associate Professor in Biolaw in the Durham Law School. She has written extensively about the law relating to obstetric intervention. What a fabulous speakers we've got. So very much looking forward to our webinar today. And over to you, Tor. Thank you.
Thanks, Suzanne. Thanks for joining us, everyone. I'm going to start by doing a very short summary about what the law is in relation to childbirth and mental capacity. And I'm going to assume no prior knowledge at all. So apologies to those of you who already know a bit about this. But I'm just going to set out the basic framework that applies, and then you'll hear in more detail about some of the issues that arise from Livia and from Sam. So how does the law have anything to do with childbirth? Well, there's a legal test for mental capacity in the Mental Capacity Act of 2005, and that applies to everyone and to all decisions. And it's a test which explains how you establish whether or not someone has got the mental capacity to make their own decisions. And the Act says that there's a presumption that people do have capacity to make their own decisions. But if there is some reason to think that a person might not be able to make their own decision, then you need to follow the framework in the Act to find out whether that's the case. And what the Act says is that you need to check whether someone has a mental impairment or a disorder, a mental disorder, or something that's stopping them potentially from being able to make a decision. And that could be some permanent mental impairment, or it could be something temporary. It could be something like a needle phobia, or it could be a diagnosed mental health problem. And it might be something in the case of pregnancy, which has existed for a long time prior to the person becoming pregnant, or it might be something short term, which has cropped up in the course of a pregnancy. But just because someone has a mental impairment or a mental disorder doesn't mean that they automatically lack capacity to make their own decisions. And so the next question is whether or not that mental impairment is stopping the person from being able to make a decision. And the way the Act describes that is that there are a number of features of making a decision that you have to be able to do. And if you can't do one of those things because of your mental impairment, then you'll lack capacity. So you have to be able to understand the information that's relevant to the decision. You have to be able to remember it long enough to use it to make the decision, and then you have to be able to communicate your decision as well. Now, the Act makes clear that you should try and support people to make their own decisions, help them have capacity to make their own choices. And if you can, you should delay making a decision until a later time when the person has got capacity. Often in the context of pregnancy and childbirth, you don't have that time because there's an inevitable point at which a decision is going to have to be made and you can't postpone it any longer. And so if you are in the territory of deciding that someone can't make their own decisions, then ultimately you may have to make a decision for them in their best interests. And the way the Mental Capacity Act works generally is to say that as long as you as a health professional have a reasonable belief that someone lacks capacity and a reasonable belief that what you're going to propose to do is in their best interests, then that's fine. You've got a defence to what would otherwise be perhaps an assault or an invasion of their own sort of personal autonomy. So generally speaking, that's how best interest decisions are made by doctors. They don't come to court, they just assess capacity, take a decision about best interests, having consulted with everybody, and then go ahead with the outcome of that decision. But if there's a dispute about what's the best thing to do, or a dispute about capacity, or if, as in the case of pregnancy and childbirth, what you're proposing to do includes physical restraint or sedation, or goes beyond what would normally be expected as part of the care that you would give to a pregnant woman, and particularly if it would go so far as to amount to a deprivation of liberty. And so that includes cases, for example, where you would be proposing that a woman have a general anaesthetic and a caesarean against her wishes. Then you have to bring those cases to court because the court has said that you need to, and you need to then defer to the judge of the Court of Protection, who will make the decision about capacity and best interests. Once the case gets to court, the court has to make the best interest decision, and the focus of the decision is the best interest of the mother, because in English law, the fetus doesn't have its own distinct legal personality. So you're not asking what would be the best outcome for the fetus, you're asking what would be the best for the mother. In practice, though, the way the courts tend to look at these cases is to say, well, most mothers, and probably this mother, would like to have a healthy baby delivered, and so they will want there to be a safe delivery, and so facilitating that will be in their best interests. Of course, it will also be in the fetus's best interests, but that's not the focus of the court's analysis. So the court in these cases will look at the familiar risks and benefits of different kinds of methods of delivery. But usually the cases that come to court have come because the doctors are concerned that the mother is not going to be very easy to manage during the process of labour, isn't going to comply with monitoring, isn't going to necessarily let the doctors anywhere near her, and perhaps isn't going to take on board advice and follow it if things take an unexpected turn, or if it looks as though intervention might be required. And so the evidence that's presented to the court is usually about the risks and benefits of a caesarean section, and why it's thought by the medical professionals that being able to carry out a caesarean if necessary, even if the mother is objecting, is the best thing to do. There's relatively little evidence that has yet come before the courts about the implications for the woman's mental health and well-being about being subjected to an intervention of that sort against their wishes. And the priority of the court in most of the reported cases is on securing a safe delivery. And inevitably, that means that in almost every case, the order that's made by the court does sanction a caesarean section, regardless of whether or not the mother thinks that that's a good idea. So the sorts of orders that the court will make will say, usually they'll have a staged process. So attempts will be made for there to be a natural delivery if that's what the mother has said she would like, but with the backup plan of a caesarean, even if the mother is objecting to it. And very interestingly, in many of the cases that have been reported, we know that in fact the caesarean wasn't actually required, and that the fears of the medical staff in terms of lack of compliance or problems that might arise haven't actually materialised. So they've gone through the court process and got the order that they wanted, but never actually had to rely on it. And one of the other issues that the court has had to look at is the problem of people's capacity fluctuating. And it's very common in cases concerning childbirth for there to be a concern that a mother has capacity now, but might lose it during the process of labour. And certainly any of us who've given birth, I think, can sympathise with that. And so the court has to be very careful to make sure that it's not intervening and making decisions for people who have capacity to make their own decisions, because that's not allowed. It's only when a person loses capacity that the court can step in and require things to happen in their best interests. So that, in a very small nutshell, is how the framework operates. And you can tell from what I've said that really there's the cases that are reported, although obviously every case is different, the mental impairment is different, the person's wishes are different, the circumstances are different. Nevertheless, the cases are all somewhat similar in that the courts tend to say that if a person lacks capacity to make a decision about the method of delivery, then if the doctors are saying that a caesarean is the safest method, then the court will almost inevitably find that that is going to be in the person's best interests. The other thing the courts say over and over again is that they don't like making these decisions in a hurry, and yet the cases that come to court almost always come fairly late on in pregnancy. If you're lucky, the court might be looking at the case at perhaps 32 weeks, but very often it's 36, 37, 39, 40 weeks. And the judges are very anxious that that is a situation that shouldn't keep happening. So unfortunately, it does keep happening. And we'll hear from Livia and Sam about some of the practical problems. But establishing whether someone currently has or lacks capacity and whether they might do in the future, and also eliciting their views and their choices, it isn't a one-off process. And so one can see that things will develop over the course of a pregnancy, but ultimately, if there's a risk that a court may need to be involved, the plan should be to get to court sooner rather than later, so that all of these issues actually have time to be looked at properly. Right, that's my very brief summary, and I will hand over to Livia next.
Thank you very much, Tor, and thank you very much for inviting me here today. What I will do is I will go over two clinical cases that are different in their story, as it were, and which, of course, have been very much anonymized because they did raise an issue of capacity. It will be useful to discuss what the problems that occurred were to give a sense of clinical reality to the issue. So the first case, we will call the lady SC, who is a woman in her mid-30s. She has 3 children already, although they don't live with her. And her most recent delivery was 2 years ago in Africa, but she left her baby there, presumably in the care of relatives, although this is not known by authorities in the UK, where she since has returned. Now she is pregnant again, although not in a stable relationship. SC has a diagnosis of schizoaffective disorder, which is a severe psychotic disorder, and a history of multiple admissions into psychiatric wards, many under the Mental Health Act. She also has rather an extensive forensic history with several convictions for assault. So she's a physically aggressive person, not just when she's unwell, but a bit in general. She often has assaulted NHS staff, but also members of the public. Currently, she is an inpatient on a psychiatric ward under Section 3 of the Mental Health Act, which is used when a patient is well known and recognized as in need of treatment when they don't agree with this medical opinion. So the Mental Health Act needs to be used to make sure that their illness is treated. SC has been refusing all obstetric interventions and becomes aggressive if maternity staff insist on examining her. She has agreed to a few scans only, which show that her baby's position is transverse, meaning that the baby is sitting horizontally rather than head down. And her blood tests on the psychiatric ward, because she has refused to have tests done by maternity, show that she has gestational diabetes, which is another big issue because it can have an impact on how the baby develops and also for the baby's health right after delivery. But SC continued to refuse all interventions. When babies are positioned transverse or breech, meaning bottom down, head up, the advice usually given by maternity is that the safest delivery method is a cesarean section. But SC refuses to consider a cesarean section on the ground that, quoting her, that God will turn her baby, and that she has delivered babies before. She knows what that's like. She doesn't want to have any surgery. She's seen by her inpatient team, of course, and they assess that she has capacity to refuse obstetric monitoring, and she has capacity to refuse to go to hospital if she's in labor, although they don't document it very clearly. On top of all of this, she also has refused to engage with the perinatal service, and therefore the perinatal service have only been able to liaise with the other teams, with maternity and with the inpatient team, only in an advisory capacity. Perinatal service suggests that the obstetric and the treating psychiatric team work together towards applying to the Court of Protection and seeking legal advice from the trust, because it is possible that SC's capacity might be fluctuating, and the fluctuations can become more intense closer to the delivery time and during labor, and of course in the postpartum period, although now the worry is, how is this baby going to be delivered? So this is a really complicated case, because of course everything developed in the course of the pregnancy. So it was not someone who became known right at the end where there was a big rush. It was someone who was known for many months during the pregnancy, but who consistently refused all intervention from obstetrics, apart from the few interventions that actually showed rather a worrying picture. So the clinicians were very concerned about what was going to happen to this lady and to her baby. And the difficulty was that it did not seem to the clinicians who were seeing her that her refusal to have these interventions was dictated by her psychotic illness. It was dictated by her preference. And people are perfectly entitled to make an unwise decision. It does not mean that they lack capacity to make that decision. So everybody's anxiety was at quite a high level. The point that the perinatal service was very keen to make was that psychotic disorders worsen significantly or can worsen significantly around the time of delivery, because there is a combination of factors that goes from sleeplessness to the pain of labor to the trauma to changes to the hormones that conspire together to increase the risk of a deterioration in mental state. And very often what we see during that time is that people's mental state can change very dramatically and very rapidly. So somebody can be coherent and okay, and then a half hour later, very, very unwell and really unable to think clearly, and then okay again for a little while longer, and then deteriorate again and be very, very sick. So there was absolutely no way, given this lady's clinical diagnosis and picture, that one could guarantee that her ability to continue making this decision would stay. So their advice was speak with the solicitors, for the obstetricians to speak with the solicitors and jointly with the psychiatric team that were treating her and were able to write up all their assessments, apply to the Court of Protection in the eventuality that this lady loses her capacity, because of course anybody can has a risk of losing capacity for whatever reason, but somebody who has got such a clear risk factor might need some additional consideration. And especially someone who has expressed such strong views when they were capacitors. It would be important, if they lose that capacity, that anything that's done in their best interest in a way has been examined and ratified and talked through also through a legal process, so that the clinicians don't just act based on their surmise in that moment in time. So they did do that, and the Court of Protection did authorize an intervention by C-section should she lose the capacity to make that decision when she went into labor, or when the time for delivery was upon her. But just to like not leave the suspense going, very fortunately for her, God did turn her baby head down. So she had a spontaneous vaginal delivery and was quite well after that. Nevertheless, everybody knew what was going to happen, and everybody had a clear plan of action, which was reassuring, especially for the obstetricians who would otherwise have been a bit stuck. So that's case one, and it was a complex case with a lot of to-ing and fro-ing and a lot of concern that people might be put in a place where they would have to act restraining a patient or in very difficult circumstances. Case two is different, and it is about a lady called AC, who is a woman in her late 20s. She is pregnant for the second time, and she has had puerperal psychosis, which is a severe deterioration in mental state at the time of very quickly soon after the birth of a baby, which onset during her previous labor. So she started becoming unwell actually during labor. She has a very dim memory of having been unwell. She and her baby were admitted to a psychiatric mother and baby unit very quickly after the birth of the baby, as soon as she was obstetrically stable, and AC recovered quite well. Now she's pregnant again, and she's very keen to remain well during the pregnancy and to remain well in labor and in the postpartum period. So she engages really well with the perinatal service, and she engages really well with the obstetric team, goes to all of her appointments, discusses all the planning. Her husband is also involved and very supportive. But for her, the main concern is that her previous labor had been very long, with no sleep for about 48 hours, and ended up in a traumatic instrumental delivery, which was very frightening, but also left some sequelae, physically speaking. AC very much wants for this not to happen again. So as is customary for perinatal services, when she's about 30 weeks pregnant, a meeting is held called a pre-birth planning meeting, organized by the perinatal team, which has present AC and her husband, the perinatal team, and the obstetric team, so the clinicians, the key clinicians involved in her care, and of course her and the husband. And a collaborative plan is put in place to make sure that everybody is aware of what the key risks are and how to minimize them, and how to treat her if she becomes ill again. And provisions are made for treatment to be available then and there, should something change in her mental state. AC really wants to incorporate some clinical instructions about her obstetric care in case she's not able to convey these instructions when she's in labor. So her worry is, what if I become really ill again and I'm in labor? I really don't want what happened before to happen again. I want to tell you now that this is what I want and this is what I don't want. I think it's quite possible that in the audience there may be lots of obstetricians, so I feel a bit intimidated in saying this. But from my knowledge of, my very limited knowledge of what happens in labor, it's always very hard to predict what's going to happen, and it's very hard to make a promise to someone to say this, we're just simply not going to do this, because circumstances might be such that you have to intervene. So the important thing is to ensure that people know that their wishes are taken into account, and that interventions that they really don't want will be kept at the bottom of the pile, if at all possible, unless they are absolutely unavoidable. And that, if at all possible, if deemed safe for mum and for baby, other intervention will be tried first. This means that some people might be very keen not to have a C-section and might want to try everything possible to avoid it, or other people actually might have strong feelings, as AC did, about instrumental deliveries, and might say, rather than going down that road, if you see that things are not working, I would prefer to be taken to theatre because of my previous experience, because it was so difficult, because it really contributed to me becoming ill. So this is very much down to what women want, but also what the obstetric team, and in her case also her perinatal psychiatric team, feel is the least risky option for her and her baby. So a lot has to do with patient choice, but also negotiating that with clinical expertise and advice until we reach a satisfying plan, which we try to stick to unless something happens and labor just makes us do something totally different that we didn't think we were going to do. And again, just not to leave people in suspense. Again, another lovely outcome. Very fortunately, this was a quick, easy, straightforward labor that progressed well, and I'm also very pleased to say that AC stayed very well, that she took some medication for prophylactic purposes, which helped her to stay well. She followed all the advice about making sure she kept some sleep and some resting times, and she and her husband organized a really good shift system so that both of them would get a bit of shut-eye. So it worked out, but we put a lot of effort into ensuring that the planning stage was sensible and reasonable, but satisfying, so that it wouldn't add to AC's and her husband's anxiety going towards a second birth, because the first had been so difficult and traumatic psychologically and physically. So these are two cases that I brought forward, and please ask any questions about parallel stories if you can think of any, or other sort of outcomes and scenario. And this is it from me, and I'll hand over to Sam.
Hi, thank you, Livia. Okay, so I'm not really going to talk about the practicalities. Instead, I'm going to try to provide a commentary on some of the cases, think about some of the issues that arise. I'm going to focus on the rhetoric that we have about maternity care, particularly in the context of women who have a serious mental illness, and think about the potential for advanced decision-making that Livia's just addressed. Okay, so if we think about the rhetoric, choice is a central tenet of maternity care. Its importance is emphasised in all of the policy documents about obstetric care, about maternity care. But the lived experience is often really quite different. So when you think about it, the 21st century has birth framed as a medical procedure. It's not really regarded as a natural process any longer. It's protocol-led. Available choices are dictated by clinical guidelines, by local policies. Regardless of whether or not you give birth in an obstetric-led unit or a midwife-led birthing centre, there are going to be policies and protocols that apply. The medical discourse is powerful. It constructs pregnancy and birth as risky, as a procedure that needs to be managed using technology to ensure that nothing goes wrong. The consequence of this, though, is reduced choice for the women who are being cautioned to act responsibly. The problem is that when women fail to acquiesce, when women say no, when they don't comply with the medical advice, there is generally a question as to whether or not they can be forced to make the right choice. The very fact that she's refusing to accept medical advice is going to open up a question of whether or not she has capacity to make decisions about birth and about labour. After that, her disagreement with medical advice is going to raise questions about insight, which appears to be becoming even more important in assessments of capacity. Now, if you go back to that seminal case in Montgomery, Lady Justice Hales recognised that the way in which one gives birth is an intensely personal decision. But if a woman is judged to lack the necessary capacity to make that decision, it's going to be transferred to a third party who only has to consider her wishes and feelings rather than give effect to them as part of the best interests assessment. Now, in the 1990s, there was a whole series of cases, and in those cases, the courts in England and Wales demonstrated a willingness to police pregnancy. They declared that it would be lawful for caesareans deemed necessary to be performed, notwithstanding the fact that the pregnant woman was refusing to consent. Unlike the US courts, the English courts have approached this matter as a question of capacity. We haven't engaged in questions of fetal rights or even interests. If the woman has capacity, she can refuse all treatment, including that required to safeguard the fetus. The 20th century cases culminated in 2 Court of Appeal decisions that emphasised a woman's autonomy is not impacted by pregnancy. A woman with capacity can, for religious reasons, other reasons, irrational or rational reasons, for no reason at all, choose not to have a medical intervention, even though the consequence could be the death or serious handicap of the child she bears or her own death, said the Court of Appeal. Now, that sounds like a ringing endorsement. It sounds like a ringing endorsement of a woman's autonomy, but it's significant that so far no court has considered the question of capacity in a case where the issue was still live rather than on appeal and found that the woman has this necessary capacity to refuse treatment. So it seems like quite a hollow victory to say that a woman with capacity can refuse treatment, given the unlikelihood that she's going to be found to have that capacity when you have a fetus potentially at risk. So that was really the 20th century cases. In the 21st century cases, particularly over the last 8 years, there has been a resurgence in these cases. So over the last 8 years, I found at least 15 reports of cases where women have been required to submit to a caesarean following a finding of incapacity. I think it's difficult to know the true number of cases because even those cases that are considered by the court are rarely reported, but actually in the vast majority of cases, women will be treated under the general legal authority in Section 5 of the Mental Capacity Act. The cases that are arising now are really quite different to those that arose at the end of the 20th century. Unlike the previous tranche of cases, the new cases almost all involve women with serious mental illness, primarily schizophrenia or bipolar disorder. I think pregnancy does represent a real challenge for women with a serious mental illness. You have to try and strike a balance between continuing the drugs that allow her to maintain her mental health and well-being and safeguarding the fetus from the tetragenic, the neurodevelopmental risks that are posed by the psychotropic medication. In a recent review of studies investigating relapse among women with bipolar during pregnancy, Stevens found that there was a relapse rate of around 20%, and that's 1 in every 5 women experiencing a relapse during pregnancy. So that's a significant number. I think it's difficult to say whether patients can ever be described as consumers of health services, but I think the notion of choice in childbirth is probably best described as an illusion, and that's particularly the case when you're dealing with a woman with a serious mental illness, a condition that automatically marks her out as different and as requiring special treatment. We have a very limited number of mother and baby units across the country. Speciality perinatal mental health services are incredibly important, but they can be quite difficult to access. It depends where you live often in the country as to what kind of care you're going to be able to access. If you suffer from a serious mental illness, you are not going to be allocated to a midwife-led centre, birthing centre. You're going to come under obstetrician-led care. Birthing in hospital brings with it the prospect of cascading interventions. For example, an epidural, for example, the use of electronic fetal monitoring. These interventions increase the likelihood that obstetric intervention is going to be required. And I think when you look at the policy documents, you see a lot is made of patient choice. But not all childbirth options are available to all women, nor are all options going to be considered valid or even responsible options. That's particularly the case where you have a woman with serious mental illness. If you look at the cases and you look at the dialogues, the discussion, the narratives that underpin those cases, what you find is that the woman with a serious mental illness may well have expressed choices, but those choices tend to be dismissed. So they tend to be attributed to her serious mental illness or to a more general lack of insight that extends beyond her mental illness into her pregnant state. When you look at the recent cases, you see that where the woman is refusing to agree, where she's not likely to comply with constructions, where she's not likely to submit to all of the interventions that have been deemed necessary to manage to monitor the process of labour, her desire for a vaginal delivery is very likely to be dismissed on the basis of safety. And I think when you look at the cases, you can see that there are two constructions of risk that are being used. On the one hand, birth, particularly vaginal delivery, is being constructed as risky, as requiring oversight by professionals. Now, this framing of risk isn't particular to women with a serious mental illness. All vaginal birth that takes place without obstetric oversight is categorised as risky. However, in the case of a woman with a serious mental illness, the woman herself is being categorised as risky rather than at risk. She is the person who is being categorised as dangerous rather than in danger. She's described as posing a risk to the fetus, to the healthcare professionals, as needing to be managed, as needing to avoid agitation, rather than as being a person who needs to be supported through the delivery. And what we have then is a medical model that's been adopted in these cases, problematising the person. She's regarded as a person with a serious mental illness. The serious mental illness is quite often the focus rather than the person. And so she becomes an object for clinical intervention. Now, in 2001, Lord Woolf, then the Master of the Rolls, said that the courts were no longer excessively deferential to the medical profession. But if you look through the recent tranche of cases, I would suggest that actually nothing has changed since the end of the 20th century, that actually a pregnant woman with a serious mental illness is just as compromised as she ever was. When you look at the cases, you see that the decision-making process, the hearing of the application, is dominated by the medical discourse. The themes of risk and control run throughout the cases. The women are supposed to remain in control, but what's actually meant is they're supposed to remain compliant. The court's consideration of the woman's capacity and her best interests foreground their diagnoses. The following discussion is dominated by experts and their views of the safest way forward. The risks, however, are generally risks to the fetus and even the healthcare professionals, not to the woman herself. The woman is regarded as being the risk, the source of the danger that has to be neutralised by a complete anaesthetic, which will render her compliant. In this context, then, caesareans are equated with safety. Vaginal natural births are constructed as risky and as dangerous. And I think this is one of the really big problems that impacts upon the way we view these cases, the way that we approach them. The women are being accused of being a risk to themselves, to the fetus. They're viewed as egocentric because they refuse to conform to dominant ideologies of maternity. And that contrasts with the vision that you find in policy documents such as Better Births that emphasise the need for personalised care centred upon the woman, the baby, her family, the provision of better postnatal and perinatal mental health care. That review concludes that women should be informed of the risks and be supported to make decisions which would keep them as safe as possible. Once a woman has made her decisions, it says, she should be respected, services should wrap around her. So the vision that's provided centres upon the woman rather than framing her as a passive recipient of care. But what I would suggest is that this vision often remains an illusion, particularly where you have a woman with a serious mental illness who's constructed as a passive subject. When you think about the Mental Capacity Act, the underlying philosophy is that individuals should be empowered to take decisions for themselves wherever possible. And so Section 1, subsection 3 requires that all practical steps be taken in order to enable the individual to take the decision for herself without success before she's deemed to lack the capacity to decide for herself. And what I'm suggesting is that the best way forward, the best way to put the woman at the centre of these undeniably difficult decisions is through a greater use of advanced decision making. What I'm arguing then is that we need to maximise the opportunity for the woman to participate in the decision and for her views to carry significant weight in any best interest decision that has to be made. For example, due to the non-applicability of an advanced decision to the situation that arises. Now, advanced decisions are actually, will take the place of a person saying no at the time. So an advanced decision, a decision made with capacity, should have exactly the same validity as a refusal at the time by somebody with capacity. We do have advanced decisions in the maternity context. So in the maternity context, we have birth plans. So most women who've had a baby will have a birth plan. They will actually set out what they want. They'll think about who they want to be present at the birth. They'll think about whether or not they want pain relief. They might decide they want whale music. There are varying degrees of importance that are attached to these different decisions. Some of them will be really key decisions that reflect the woman's critical interests. Some of them will be much more aspirational. What I'm suggesting then is that actually we need to think about birth plans as advanced decisions, that we need to look at formalising these decisions, particularly for the key decisions about, for example, whether or not the woman would want to have a caesarean. Of course, when we think about birth plans, as both Livia and Tor have said, birth is notoriously difficult to plan. Things change. You have to be able to respond to the moment. But there are certain decisions that are absolutely key, that we can say, well, no, actually, I would not want to have a forceps delivery, even if that led to and continue from there. So you could make very specific decisions. Many women will say that they don't want to have pain relief. And this is the argument that's always used. You know, the woman who, thinking about birth, thought, actually, no, I don't want to have pain relief. I want to have the most natural birth possible. She's now in labour. She's finding the lived experience not quite as she'd expected. Her partner is helpfully saying, no, she said she didn't want pain relief. No, ignore her. And she's saying, no, I do. I want an epidural. She gets to make that choice because she has capacity. So she gets to change her mind. The problem we have, though, with the women who have serious mental illness that we're talking about is that whilst they're in labour, they may well no longer have capacity. And that's why I'm suggesting they need an advanced decision to make those decisions at a time where they have capacity to take effect when they no longer have the capacity. Of course, that does mean that they're not able to change their mind. This possibility was addressed by Mr. Justice Hayden in the most recent case that's been reported, and that's the case of Guy's and St Thomas NHS Trust and R that was heard in January of this year. That case involved a woman who'd been detained under the Mental Health Act. She was 39 weeks and 6 days pregnant, so she was going to give birth very, very shortly. All had agreed that she had capacity. So the obstetricians, the psychiatrists, everybody agreed that she had capacity. But there was real concern that she might lose capacity during labour and that a caesarean might become necessary. She, however, was adamant that she did not want a caesarean. Absolutely not. She said, a caesarean is the last thing I would want. Now, remember, she has capacity at this point, and she is saying a caesarean is the last thing I would want. Mr. Justice Hayden said that this statement would not constitute an advance refusal in the terms of the Act, not just because it wasn't a signed written document with a witness, but because he said it wasn't sufficiently coate. He said that an advance refusal would have to be much more specific in order to be valid and applicable, saying that a woman might choose not to have a caesarean even though her own life is at risk, but elect to do so if the life or health of her baby is compromised. Also, he distinguished the capacitous adult who has consciously waived the right to change her mind upon loss of capacity by saying that R couldn't be recorded as being in that position on the evidence presented. Of course, that issue could have been addressed with R. He recognised that in granting a declaration that a caesarean could be performed if R were to lose capacity, he was going against her previously expressed wishes. But he said that caesarean sections present particular challenges, even weighed against all of these circumstances. He said the inviolability of a woman's body is a facet of her fundamental freedom, but so too is her right to take decisions relating to her unborn child based on access at all stages to the complete range of options available to her. Loss of capacity in the process of labour may crucially inhibit a woman's entitlement to make choices. At this stage, the court is required to step in to protect her, recognising that this will always require a complex, delicate and sensitive evaluation of a range of her competing rights and interests. The outcome will always depend on the particular circumstances of the individual case. What that means then, and this is where I would really welcome some discussion, is that actually constructing a valid and applicable advance decision is going to be incredibly difficult, because if Mr. Justice Hayden is right, then a very high degree of specificity is going to be required. And I think I should leave it there. I think I've already gone over my time. Okay. Thank you.
Very much, all of you. That was it's hugely fascinating, but just so complex. And obviously, you've got in the mix of consent as well. We have got some questions, and we've actually got one of our obstetricians who was, and I was going to actually ask this question about whether actually women have asked for intervention and they weren't allowed to give it. And Mark Waterstone was saying, in the High Court attendance, one argument raised was in fact focusing on the well-being of the baby, as it was considered that a poor outcome would adversely affect the mental health of the mother if it occurred when her condition was worse, and then she realised what had happened once she was better. I believe that this is a new position the courts are being asked to take. I don't know if any of you've got a comment about that.
So I was going to say, I think it's right that there's more thought being given to exactly whose interests and what factors are feeding into the best interest decision. And the courts are always, in my experience, they're always anxious when you remind them that they're looking at the best interest of the woman, not the best interest of the fetus, because I think it's very difficult for the judges to accept that that's what's happening, because if they are confronted with someone who is literally saying to them, I would rather die than have a cesarean, they, as Sam's just said, the judge is going to want to be 110% sure that that really is the person's view before they do anything that sanctions it, because I think their starting point is, okay, you don't want a cesarean, but if the position was that it was either that or you die, or either that or your baby dies, surely you change your mind. And so I think that's sort of the way the courts tend to sort of look at it. And so they have started to find sort of more creative ways of trying to explain why it is that a successful delivery and a healthy baby is in the mother's best interests, rather than it being in the fetus's best interest for that to be the outcome. And I think they have started to sort of explain that, and you didn't see that as much, I don't think, previously. And I think there has been, probably because the judges have been asked to confront this head on and not just sort of fudge it, to explain why it is that these things are in the mother's best interest. And they've done that, as we've seen, in these sort of slightly more creative ways, to say that, well, you know, the mother at some previous point said that she wanted to have this baby, therefore it's part of her best interest to achieve the outcome, the overall outcome that she said she wanted, even if the steps that we need to get there are ones that she's actually said she doesn't want.
Looking at from cases I've done, but I'm not particularly with capacity, but certainly consent, I think it can be a bit of an alien concept to doctors that women would want choice in terms of having something that could be detrimental to the health, and trying to unpick that capacity as well. I think it's quite difficult. We've got another question from Natalie Matthews. One of the main principles of the Mental Health Act is that, Mental Capacity Act, that a patient without capacity is given the same choice as someone with capacity. I would have thought that if a C-section is recommended due to the safety of the baby, that would be the same result when someone has capacity and for someone who lacks capacity.
The obstetric recommendation would not be different. And cesarean sections are recommended, I think, if they are considered necessary clinically. So certainly the clinical recommendation would not be different based on whether a woman is capacitous or not, but also very few people who have a psychiatric condition would just not be capacitous for very extended periods of time, because presumably they would get treatment that would help them get better. And if they didn't have capacity to make decisions about their obstetric care, hopefully they would regain that capacity at some point, and would be able to make a capacitous decision. And ultimately, whether they are capacitous or not at the time of delivery would require an assessment then and there. So when the question is, okay, are we wheeling you into theatre, yes or no, that's the point where that's another time when their capacity will need to be assessed. And even if they were not capacitous up until that moment, that is the time when their capacity must be assessed again. And what is increasingly happening now that perinatal services are much more widespread around the country is that when women enter the service, they should be asked by the clinicians who are assessing them, ultimately, what do you want to achieve? What really matters to you in terms of this pregnancy? What is the outcome that matters most? Almost invariably, women say, I want to be well and I want my baby to be well. And ideally, I would achieve this with a natural delivery or whatever else is their preferred option. But people might also say, when they are well and capacitous, what I really don't want is, I really don't want forceps to be used, or I really don't want to have a cesarean, even if it means that I die, even if it means my baby dies. If they say that, of course, they put the clinical teams in a difficult position, but that is, as Sam has said, that is the woman's decision, and it needs to be respected so long as she has the capacity to make it. I fully expect that such a controversial, difficult decision would require, would make the obstetric team seek some legal advice about it, because I think it would be wrong of them not to make sure that they've explored every avenue of care, rather than let a woman die or a baby die. But ultimately, if it's the woman's decision and she has the capacity to make it, and it remains unvaried, and she's the capacitous at the time of delivery and decides that she doesn't want a section, Tor will correct me here, but I think that the law will basically uphold her choice. So it's absolutely crucial to ask women early in their journey, what is it that really matters to them, and to record that wish, and to continue to assess if that wish remains the same, so that there is information, and if something changes, it can be taken into account.
The questions are hotting up here. I've got another question from Twitter. to all of you, in your experience, do you think attitudes towards patients lacking capacity are different in maternity care as opposed to other areas of medicine? And I guess they are, but it'd be interesting to have a chat about that. That's from Eleanor on Twitter. Victoria?
Go on then. Yes. So if you look at that just based on the reported decisions of the Court of Protection, I think you would have to say that it is different, because there are cases in the Court of Protection where the courts will accept that people who are making decisions that will end in their own life ending have got capacity to do that. And there are decisions where Court of Protection judges say, you don't have capacity to decide that, but because it's your very strongly held wish, I'm going to say it's in your best interests. You don't get those scenarios cropping up in the context of childbirth and delivery methods. Now, it's possible there are unreported cases where those have been the outcomes and we just don't know about them. But I do think, as I said before, that the courts would want to be so incredibly certain that those risks were ones that the woman had appreciated and was definitely saying she wanted to take before they sanctioned it. And I do think that the added component, if you like, of the fetus is something that does alter those decisions. And I mean, it's a really interesting question, because if you look at different types of mental illness and the way in which they're treated by the courts, you do see very different approaches to things like anorexia and refusal of artificial nutrition compared to childbirth decisions and so on. So I think there is some degree of difference of treatment. But I always think that with the Court of Protection, the only way to really understand these judgments is to imagine you're the judge and imagine what it is you're being asked to do and think, ooh, crikey, would I want to do that? Would I have the guts to say, okay, I'm going to go along with that view that you're expressing, even though I'm being told by this raft of professionals that every single aspect of it's incredibly risky and that the child might die and that the mother might die. And I think when you have to sort of put yourself in the judge's shoes to understand how they then look at this evidence that's being presented to them and why they might demand incredibly high standards in terms of knowing what people's previous wishes were before they'd be willing to accept them.
Thank you. I've got another interesting question from Rachel Clark. To what degree do you think healthcare professionals understand the complexities of best interest decisions versus their own recommendation for care? Thinking particularly about the recent Oxfordshire COP case on contraception, which determined a woman had capacity to make a decision on antenatal care and method of delivery, but not on postnatal contraception, seemingly because that was the only aspect she agreed with the doctors on. So how far do we think the healthcare professionals understand the intricacies of best interests and the complexity of it? Or are they just thinking safe, 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 and that's their priority? Livia, you're smiling. Sam, Samantha?
Do I have to take this one? It's a bit loaded. It's a very good question, and I don't think that it's such an easy question to answer, because of course healthcare professionals are not all molded in the same way. So some might have a greater sense of, might be more reflective than others, of course. There are personal susceptibilities, there are personal professional histories. People might have seen incredibly tragic outcomes, and that might actually guide how strongly they propose their plans to future patients, because they've seen how wrong things can go. And so, you know, healthcare professionals are people just like everyone else who do the best they can, with sometimes only the ability to to assess the risk. They can't predict, they can't foresee the future, as it were. I think that increasingly, I think that Sam has a point that things are still, you know, have a long way to go, but increasingly there is a greater awareness of the importance of best interest, or incorporating best interest in decision making. And there is also a greater emphasis on collaborative working across and among specialties, which means that it is possible to seek the advice of other specialists who perhaps spend more time thinking of best interest because they deal with loss of capacity more often, meaning perhaps the psychiatrists. So it is very often that if an obstetrician has to make a difficult decision and they think that capacity is an issue, they might ask the psychiatrist or the perinatal psychiatrist to join their assessment to have a more rounded view of the patient's capacity and potentially what their best interest might be. I don't know if that answers the question. It's certainly not infallible, and professional and individual views stay with us, but we have increasing guidance and we are increasingly aware of the fact that we should not let our own principle, our own beliefs, our own views guide a decision made for, you know, or an assessment of best interest is a better way of putting it. And clinicians are increasingly aware that they can call themselves out if they feel that it's too controversial. They can say, well, my belief system or my opinion is so strong that I don't think I can be objective here, so I will leave it for another colleague to make this intervention or make that decision. I think my experience is that there is increasing awareness and increasing freedom, although things still can improve a lot. But we're working at it.
I remember giving a talk years ago, and there was a GP in the audience, and I said something in the talk about how just because someone didn't have capacity, it didn't follow that the thing that was in their best interest was the most sensible thing. You know, it might be that it's in someone's best interest to do something that isn't the best possible option that everyone can think up based on other factors. And after the talk, the GP came up to me and said, oh my goodness, that was just such a light bulb moment for me, because really that is how I've looked at best interest, was that the person lacks capacity, what's the sensible thing to do? We have to do that. And if we don't have to do that, then, you know, that really frees up the sort of decisions that might be made. And I think that is technically that's true, but then again you can then see in the cases, particularly in this area, that the courts do make the sensible decision each time. They follow the advice of the treating doctors who've come and proposed the particular care plan. Usually in the Court of Protection and medical treatment cases, there will be a second opinion or an independent expert opinion sought, either on capacity or best interest or both. But very often in these cases, they come to court very late on and there isn't actually time to have those independent assessments. And so that can in itself be a problem, because you can imagine that, you know, you could get a room full of obstetricians and ask them to answer various questions about whether they think vaginal delivery is safer than cesarean or better than it in some way, and you'd get a whole range of different answers. But in these cases, the court is being presented with the particular views of the people who happen to be the treating doctors, and it's much harder because of the time constraints to get some of that wider information and other perspectives in front of the court.
It would be quite interesting to know if actually there is any judges that have actually gone against the doctors when best interests have come to court and disagreed with the capacity issue. I suspect there's not any of those.
In relation to childbirth cases?
Rochdale.
There are a very few. Yeah, Sam can say more about the details.
Yeah, so I can think of one case where they've disagreed with the obstetrician on capacity. That would be the Rochdale case, where the obstetrician thought that she had capacity and the court decided that she didn't have capacity. I think the best interest test, I do think clinicians understand it. I think that, well, they understand it as far as any of us understand best interest. The whole point about best interest is that it's an incredibly flexible assessment. And if you ask me what someone's best interests are, I may well say something different to what Victoria might say, to who may well say something different to what Livia might say. So there are lots of different views that come together when you're making a best interest assessment. I think one of the key problems in this area, well, there are two. One is that there are no second opinions normally in these cases, because they're almost always heard as emergency hearings, so you almost never have a second opinion. The other one is that the woman is generally not represented. So you may well have the official solicitor involved, but the official solicitor isn't representing the woman. Instead, the official solicitor is representing her best interests, not what she actually wants. And I think that really does make a massive difference to the assessment of best interests.
I think we're going to have to wind it up, but it's absolutely fascinating. Another one from an obstetrician, which is a difficult one, I think, but from my perspective, I probably think it's a good idea. Should all women be asked for their consent in the antenatal period to all possible interventions once in labour, in case they are deemed not to have appropriate capacity because of pain or emotional distress at the time the intervention is required?
Well, I think it's quite dangerous to talk about women as lacking capacity just because they're in labour because of the pain and emotional distress of the time. I would suggest that that's not the case. And there have been a number of studies that have been published about pain relief and the impact that that might have on capacity. And they've all come to the conclusion that actually a woman will normally retain capacity. It's not about the pain relief. In terms of asking a woman to sign a blank check to do whatever you want to me if I'm pregnant when I'm in labour, that sounds to me to be really not the way forward. We're supposed to be talking about empowering individuals, about patient choice, about a partnership really, and shared decision making. So I don't think that a blank check is the answer, that as soon as you become pregnant, you sign a consent form to any and all intervention. But I do think those discussions are going to be really important. And Livia talked about them happening around the 30th week. I think actually my view would be that they should start earlier, that actually the key to avoiding the kind of cases we see is to have these discussions going on right from the very start. The ideal is that you've got preconception counselling, that you've got planning going on before the person becomes pregnant. But where that's not possible, I think that the discussions can start much earlier in the pregnancy and bring everyone in together. So you should have the psychiatrists, you should have the midwives, you should have the obstetricians, and actually look at developing a plan together that is going to take account of the medical realities, but also take account of what the woman wants. Her partner could be involved. There are all kinds of possibilities for actually making her part of that decision. And hopefully she retains capacity and there isn't an issue. But if there is an issue, at least that way you know what she wants and you've involved her at the start.
I think that's right. The consent process is what I've meant. That it's a constant growing thing throughout the duration of pregnancy. So you've got the input from what the woman wants throughout that, and I think that's exactly right. I've got to stop us there, but I think we've got to stop there. It's been absolutely fascinating. We could go on for another hour actually. I can't all thank you enough for volunteering your time today on this webinar. Very enjoyable indeed. And thank you very much for your time. Thank you. Bye-bye.
Thank you for having us. Thank you.